I'd like to welcome everyone to this virtual town hall webinar, Global Anesthesia Priorities in the COVID-19 Era. We're very excited to have wonderful partners with us, including the WFSA, Smile Train, JICS, and Baylor University and Lifebox. We have a great lineup of speakers today. I'm very excited to hear about the topic of global anesthesia. And it's very interesting because we have a wide range of regions that are representative with our speakers. So it's wonderful. So I just want to put out a warm welcome from Geneva, Switzerland on behalf of the United Nations Institute for Training and Research and the Global Surgery Foundation. And I look forward to this webinar. So Megan, I'll turn it over to you for the introductions and thank you very much.
Thank you, Jeff, for the wonderful introduction. Thank you so much, UNITAR, for hosting this, as well as the involvement of all of our partners, the Global Surgery Foundation. I am so privileged and honored that, you know, Smile Train even approached us at Baylor College of Medicine to kind of come up with this wonderful idea. And I'm so glad that I was able to work very closely with Sarah Hamilton from Smile Train, as well as Faye Evans, who has a lot of affiliations with Lifebox and WFSA, and of course GICS for their support. So I really, really appreciate it. But we were just so excited to kind of think about this very serious topic. So as far as coronavirus and its impact on our world, it's entirely changed our day-to-day lives. And on top of that, as providers, our surgical and anesthetic systems have completely been altered. And we've had a few discussions, I think, as an international community, how you know, surgical systems are coming together with, I feel, a very strongly surgeon-led voice, which is great as I'm a general surgery trainee. But I really want to know more about what our anesthesia experts are thinking and feeling around the world. And I can tell just from working in a COVID unit with patients on ECMO, trach, you name it, the world is already very different. So again, I am so thankful that we're all doing this together now, and I really want to have the privilege and opportunity to present our moderator for this session, Dr. Mary Nabukenya. She is, if we go forward another slide, you'll see her beautiful picture. But Dr. Mary Nabukenya is from Makerere University College on Health Sciences in Kampala, Uganda, and she will be presenting and introducing the remainder of our panelists. Our goal is for the panel discussion to be the primary highlight of this. So please, participants, please do submit your questions, and let's make this a very good discussion about what our priorities should be in our global anesthesia with our global anesthesia colleagues. Thank you.
Thank you very much, Megan. It's a real pleasure to be here. Thank you for inviting me, and I'd like to thank the organizers for putting this together, and especially for putting together an outstanding team of panelists from different parts of the world. And it's a real honor for me to introduce them. And I will go on to introduce our first speaker. If you can, Julia, if you could just move on to the next. Yes, our first speaker is Dr. Rebecca Gray, who is a pediatric anesthetist at Red Cross War Memorial Hospital, Children's Hospital, University of Cape Town in South Africa. And she's going to be telling us about her experience in South Africa. Thank you very much, Rebecca. The floor is yours.
Thanks, Mary, and thanks, everyone. Hi. So greetings from Cape Town in South Africa. As you've heard, I'm a pediatric anaesthetist at the Red Cross Children's Hospital, and you were right to be on that slide, Julia. Next one. We're one of only 2 freestanding children's hospitals in the region, and we cater for children up to the age of 12 years. Advance the slides. We've had our first confirmed case of COVID in the country at the beginning of March, although it's highly likely, given the large number of European tourists that visit us in the summer from December to April, that we had many unconfirmed cases before that. And I think this is probably the case for many countries who have got a tourist industry that maybe they picked up quite late on those infections. We stopped elective surgery, which at the beginning of, or at the middle of March, and stopped our outpatient clinics at that stage as well. And that meant from that stage, we were just running four emergency lists per day. And at the end of March, the country went into a full lockdown, initially for 3 weeks, but 5 months later, we're only just coming out of it in stages, and we're at what we call level 2 currently. So we used that time, and that's a graph of our infections over time. And so initially, we had very few infections, and we used the time to train staff and to develop protocols. You can advance the slide. We had to redeploy some of our anesthesia staff, and that's also where we were busy, to the adult hospitals. And at our adult hospital in Cape Town, we provided as anesthesia a very labor-intensive 24-hour intubation services for all cases, anesthesia and ICU, who were suspected or known to have COVID. Our staffing levels were very stretched at this stage, and so stretched that, in fact, as senior anaesthetists, my colleagues and I were doing resident calls on the weekend just to make sure that the residents were at least getting 1 weekend off in a month. The early days of lockdown were a tremendous, a time of tremendous pre-traumatic stress. I would almost say there was a pre-traumatic stress disorder, and I'm sure that many of you can identify with that. Our staff, particularly the nursing staff and the support staff, were extremely stressed and extremely fearful, and we had high levels of absenteeism, just people staying away from work, not wanting to be around. And quite a lot of dissent as well. But gradually this was replaced by a heads down, all in this together, really cohesive spirit, as we had staff that had been infected and they came back to work. And they recovered. And most of those infections probably took place on public transport or at home rather than at work, given that we're a children's hospital. And as you can see from that graphic that's up there, these are ones that pop into my WhatsApp inbox every couple of days. As of the 7th of September, we had 156 staff infections, and in total 152 people had recovered. We just had 3 that were still recovering. And overall, we've only had 1 death of a colleague in our hospital over this period of time. At that point, we treated 159 inpatients with COVID, and many of them had been admitted for other conditions, not for COVID. And last week, we just had 2 of them still as inpatients. Having so many staff infected also meant that obviously we had contacts. I'm still busy with the previous slide. Obviously meant that we had contacts that were self-isolating, and it really impacted on service delivery. So even when the overall case numbers in the country were going into decline, and even when we realized that we weren't going to be flooded with pediatric patients, we still weren't really able to consider increasing our services. So for the first 6 weeks of lockdown, we really only did urgent and emergent cases. And our case definition was something that can't wait for more than 3 months. But as you can see, 5 months down the line, we had to revise that. And so you can advance the slides now. We slowly started bringing up our elective lists from May, with the proviso always that if staffing levels declined again, we would need to cut lists, or we may need to interrupt lists. And that's been hanging over our heads ever since as a possibility. So next week, we're hoping to be back at full operating capacity, but again, because of the very nature of the pandemic and the fact that we're expecting it to last for a while, we may need to, as I say, cut back on services or interrupt lists. And essentially, what it really calls for is extreme flexibility and teamwork to be the name of the game in our work in theatre. We always are a teamwork setting, but really real flexibility to ensure that the limited resources that we have are used optimally. It really also means that we mustn't waste any time in theatre now that we've had so many cases cancelled in lockdown. We've got so much catching up to do. So we really have to use our theatre time super efficiently from now, and that for me is going to be a big focus. And on that note, as anaesthetists, we need to work out what the minimum number of staff that we would need for a theatre complex to function, and we must make sure that we don't run below that and avoid and risk compromising patient safety. And this is really each setting will need to work this out for themselves and work out what is right for them. surgeons seem to be a bit more fluid, and Megan, it'd be interesting to hear your comment on this, but in my experience, surgeons seem to be a little bit more fluid, and we almost never have a surgeon cancelling a list. But sometimes I do see them stretching themselves a little bit far, a little bit thin in the amount of cover that they can provide junior operators. I'm not too sure why that is, but that's definitely something that we need to keep an eye on. And, you know, perioperative patient safety is our very special concern and something to be very vigilant about. We can move the slides on. One way in which our hospital has previously approached overburdened surgical waiting lists is to organise privately funded lists that run on a weekend. And this might be something that other centres could consider doing using donor funding. The lists happen on the weekend to allow surgical, anaesthetic, nursing and support staff to earn extra cash. So you're paying the people in the hospital themselves, and that provides quite a nice incentive. The cases are chosen to be simple, preferably day cases, or at least dischargeable the following day, so that they don't fill the surgical wards up during the week when we need the beds for elective lists. So we usually have this running for a couple of months every year because we often found our waiting lists mount up. But during this COVID time, we're hoping that we'll be able to extend that and run it for a significant amount of time to cover the operating time that's been lost during de-escalation. You can move on now. Another impact on our services has been the closing of the borders, and our hospital relies to some extent on voluntary fellows in the surgical, in the medical and in the anaesthetic disciplines. And a large number of these fellows chose to go home, both to be close to family during the pandemic and also because they were needed to provide medical services in their own countries. These borders are still closed, and we live in hope that they will be opened shortly. But even when they do open, we're not too sure how many people will be able to come back because financial circumstances have changed. And this has got real consequences on our staffing levels and ability to deliver a service, because we do to an extent rely on these volunteers. But it's got huge implications for the training of these doctors, technicians and nurses, many of whom have been sent from their countries of origin to train with the expectation that they will then come back and lead a service when they come home. So this could be a huge loss for national health services throughout Africa. And we really need to be looking at ways to complete training for people who've missed out in this way, as well as for ways in which we can continue to support the training of these people in health systems when we can't get them to our own hospital to train if we're existing in this closed border situation for an extended period. Okay, I had a bit of a thought about what the specific challenges are to paediatric anesthesia, and these are things that I've been seeing in my practice. I think we're all paediatric here, but this will probably also relate to adult anesthesia as well. In my experience, the patients are much sicker than they have been before the epidemic. They're often avoided coming to hospital until really the last minute, because they're afraid of catching the coronavirus in hospital, and also because the lockdown has had a devastating impact socially, and we've had massive increase in poverty. People are just too poor to get to hospital easily. They don't have the resources. So that's also why they're arriving so late. And coupled with that, we've seen an increase in malnutrition. We've certainly seen it in our patients, and I have experienced one perioperative death during this period that can in part be attributed to malnutrition. And for the first time in ages, I'm reading up on anesthesia and malnutrition, and I've just put a little resource in there for you if you would like, and that's a free article and update on anesthesia from the WFSA on anesthesia in the malnourished patient, which is useful. Chronic diseases, it's the same story. People aren't coming into hospital to fill their prescriptions because they're afraid of catching COVID, or because they've run out of money. They're missing appointments, so no follow-up for that. We've had a 25% decline in immunization in South Africa. I'm imagining the impact will be like that throughout the continent. And so we're likely to see an increase in vaccine preventable infections. And as long as we've got COVID going on, which we're expecting for the next couple of years, we'll have this multi-system inflammatory syndrome around. And so that's just something to bear in mind when kids do come for to theatre. If they incidentally have COVID, there is the possibility of this. And this was a letter that was published by the group in Cape Town, and 2 of the 23 children that they were reporting on had actually come to theatre for appendicectomies. So the myocarditis and the cardiac dysfunction is certainly something to consider. So the way forward, well, I think we need to be preparing for sicker and more malnourished patients, careful assessment, preparation for all the issues around that. All of us need to be sure that we're keeping up to date with our screening recommendations updated. Temperature, we're expecting might fall off the recommendations, that the screening and GIT symptoms seem to be much more important in children. I'm expecting those to appear soon. And then this was something that I've been toying with for my cases, particularly when we've got a known COVID or a suspected COVID case, is rather using sedation or a total intravenous anesthesia and avoid instrumenting the airway. So, and with that, reducing aerosol generation. So it would be good to see some work coming out around that, and maybe some training around options, so that sort of thing. I've said a focus on theatre efficiency. I mentioned why that's so important. We need to make sure that we get as many cases done in the time that we have. Preserving resources really around PPE and making sure that we save it for the known or suspected cases, and maintain caution around other cases as well. And then what I feel strongly is that we constantly need to revisit what can be achieved virtually, especially in the realm of training. And we've had some really great advances in that, just out of the necessity of lockdown. And so hopefully we can continue to use our imaginations in that and see what we can accomplish. Last couple of slides, some great things that I hope will stay from this time is virtual meetings like this one. They've been a great, it's been super to see those blossom. A free sharing of resources, but always check what is fact and what's extrapolation or opinion. I've certainly been caught out there a few times before broadcasting them, and be sure to credit the creators. And then I've loved the homegrown solutions. We've got a makers club in our hospital, and people have come up with these face shields. The bottom right there is a little fan to stop your goggles from misting up, and on the left we've got a filter that you can attach to the deflation port from when you're deflating from a laparoscopy. That's been lots of fun. And last slide was just infection prevention practices, hand washing. We've had a dramatic decrease in hospital-acquired infections in the country around this period, which was a bit sobering. So hopefully we get better at that. And my very last slide, and a last thought, I couldn't work out quite how to include it all, but this is a hugely important topic, and that's burnout. It's affecting all of us. We need to acknowledge it. We need to be kind to ourselves and to each other. You need to take brief but total breaks when you can. And you need to work this into your strategy when you are managing people, and recognize it early. So that's me. And on my last slide, there's a QR code with a contact card for me. And I would just be so grateful if people would be in touch. Thank you very much.
Thank you, Rebecca. That was a great sharing of your experience. We'll just move on to the next speaker. And our next speaker is Dr. Fauzia Khan, who is a professor and consultant in the Department of Anesthesiology at the Aga Khan University in Karachi, Pakistan. And she's also the chairperson of the Safety and Quality of Practice Committee of the WFSA. You're welcome, Dr. Fauzia.
Thank you, Mary, for inviting me to be a participant in this meeting. Now, this title slide shows the map of Pakistan. It's a lower middle income country, which is situated in South Asia. And it has a population of about 200 million. But the health budget is very, very small. It's less than 1% of GDP. Can you move on, please? Next slide, yeah. So this slide shows the situation in the middle of June. At that time, we nearly had about 7,000 cases and the hospitals were filled up, and there were reports of shortages of oxygen and critical medicine. And people were anxiously sharing stories about shuttling from one hospital to another, searching for space for patients who are suffering from COVID. Next, please. So in the next 3 slides, I have listed the general challenges which have been faced by the government, by institutions, and by healthcare workers. And since anesthesiologists have been in the forefront of this pandemic, so this applies in general to our specialty well. So the challenges that were faced by the government were a burden on an already fragmented and underfunded health system. There was limited capacity to impose complete lockdown. And in the initial days, there were no standard operating procedures, limited diagnostics and treatment in quarantine facilities. This though improved in about 2 months or so, when the government provided quarantine facilities and the diagnostics got much better. There was little baseline information about infrastructure. In fact, we did not know how many critical care beds were present in teaching hospitals, and only educated guesses were being made. So there was shortage of hospital beds, critical care beds, there was shortage of medication, equipment, and workforce, which was already low on the anesthesiology and also on the nursing and paramedical side. It was again stretched to its maximum. And on top of it, there was indifferent attitude of general public. Next, please. Then there were institutional challenges, and these were like setting up of dedicated facilities in limited time. There was the question of training of staff. Availability of personal protective equipment was an issue. This is a little study that was done by some doctors in our country, which this was done in June. And this shows that only about 37% of the healthcare workers had access to N95 masks. And there was reuse of personal protective equipment by 60%. This was a multi-central study that was done in June. Then maintaining routines. I mean, there were patients present in the hospitals and you needed staff to look after them. And keeping up with the changing disease patterns. There were new information coming every day. And another challenge was keeping the staff positive, motivated and productive. And there were society pressures. In our type of society, I mean, there was at one time, there was a minister showing up with his relative and asking for a bed to be provided because, you know, it was his relative. And though there were no beds, so, you know, something had to be done. And another problem was violence against staff. Staff who was working in ICU and in ER. It was not unusual to witness public smashing hospital equipment when their loved ones died because it was considered a mistake by the physicians. Next, please. Individual challenges, an already stretched workforce. There was overwork, home routines of people were affected, lack of PPP I've already referred to. There was fear of the disease to oneself and to the near and dear ones. And there were stress effects. And in fact, there were suicides reported due to lack of protective measures among physicians. And nearly about 500 health workers were affected and 3 doctors were killed. This was till July figures. Fortunately, in our hospital, we had some residents and consultants who contacted the disease, but we did not have any mortality. Next, please. This is where we stand today. This has been taken from the website of Pakistan government. These show the figures from September the 3rd. We've had a significant decrease in the number of deaths due to COVID, and September the 3rd only showed about 7 deaths. And the graph on the right side shows the countrywide COVID-19 deaths per million of population. And I think we are better off than many, many countries at present. It was predicted that Pakistan will see around 80,000 deaths till August 2020. But fortunately, that did not happen. And there are some very interesting theories going around regarding the low mortality in our population. And one that is the most favorite one is that we have got a younger, significant number of younger population. 2/3 of our population is less than 30 years of age. Next, please. Now, this is a photograph of my university where I work. This is the first private university which was established in 1988 in Pakistan. And it also has a campus in Kenya, a medical campus, but there are other campuses that are present in other parts of the world. It has about, it has a 700-bed hospital, which is a tertiary care hospital and a medical and a nursing school attached with it, and a postgraduate training program in almost all disciplines. And one of our mission statements is to respond to the identified needs in the country and the region. So in the next 2 slides, I will take you through some points which highlight how such a tertiary care center can respond to the needs and provide leadership in such circumstances. The first case of COVID that happened in the country presented to our hospital on the 26th of February, 2020. Just following that, a multidisciplinary team was constituted and anesthesiologists were part of this team. Rigorous infection control procedures were put in place. There was an acute care unit next to our emergency room, and this was converted to COVID ICU in record time by our engineers, providing negative pressure ventilation, which was not present there initially. We also were fortunate that we have a 3 operating room complex, which was for orthopedic surgery. It had negative pressure. And so these were converted into COVID-19 operating rooms. And we stopped all surgery initially and then started with only emergency surgery. And later, about 2 weeks later, we also added urgent cases were scheduled there. All surgical patients were then tested preoperatively for COVID. Our resident schedules were changed. Our postgraduate medical education committee recommended that residents have 1 week on and 1 week off to decrease their exposure. Our on-call consultant schedule also changed. We usually have 1 consultant on floor at night, but then this was changed to 2 consultants because intubating teams had only consultants going to intubate the patients. Then we also had staff training videos on PPP donning and doffing made by the anesthesiologists and also for intubation. Next, please. Same time, a COVID-19 research coordinating unit was established. We also, because of the shortage of PPP at times, we had local developments of the PPP, face shields and gowns. Telehealth services were started in our institution. The government asked for our help and we were helping. We started advising the government and other institutions. There was a task force created by the government and some physicians from our hospitals were part of the task force. Then there was a grant given by the government whereby our institution started what we call tele-ICU and started training staff in critical care at national level. And also training the government staff in PPE use. And also the institution helped the government in making isolation centers in Karachi. In addition to that, we were also involved in educating the publics, and for this, medical students were used as well. Next, please. So what are the future challenges? The disease is still there. And it's like the glowing embers. So if the right environment is provided, more oxygen, when, you know, fire can erupt at any time. But I find that the attitude of people has become somewhat lax. Even the healthcare workers, when they're anesthetizing patients, I don't find the same, they think that the disease has gone. There is no organized psychological support facilities for staff or for the community. And this is a big issue, I think. There is no mechanism of follow-up on patients, those who have suffered, those who've been in ICU. So they've been, you know, just let out in the community. And then there are production and economic pressures. We started our elective surgery about 2 weeks ago after the drop in the number of cases. But we still have time limitations on the surgical work. Normally our lists go on till about 8 p.m., but we are not allowing them to go beyond 5 p.m. at the moment. And weekend work is not being allowed at present. But the patients are keen, the surgeons are very keen to go ahead because ours is a private institution, so that is a lot of pressure on anesthesiologists. The COVID ORs are still kept separate, and all the COVID positive patients are being done on those ORs, or if you don't know the status of the patient, they're being done in these COVID ORs with full protection. Next, please. So with this, I finish the presentation, and we'll go to the discussion later on. Thank you.
Thank you very much, Dr. Fauzia. We'll move on to our next speaker, who is Dr. Ekta Rai, who's a professor of anesthesia at the Christian Medical College and Hospital in Vellore, India. Dr. Ekta, you may start your presentation. Thank you.
So good morning, afternoon, and evening to all. Please accept my wishes as per your timings. It's indeed an honor to be here and talking about, though it's a daunting task to kind of summarize Indian perspective with COVID-19 and anesthesiologists. So can I have the next slide, please? So you can see that India is like this. You see, with a population of 1.33 billion, and you have so many, population of so many countries, and COVID being a disease which spreads with close contact of people. The spread is human to human. And the major thing which saves you is social distancing, saves you is, good hygiene. And you can understand it's a big struggle for my country. So I have put some data here, which is by ICMR. Can we go back to the last slide? With ICMR stating that we have done kind of 55 million tests till now, positives of 4.75 millions, and we have a very good recovery rate. And as Dr. Fauzia said, probably the cause is we have a younger population with us. And we do have death rate of our incidence of around 1.6%. Next slide, please. So I think the best thing which happened to us was this disease started in Wuhan in later part of 2019. And we really got to see our first case around March or end of February. And so really we didn't have so many patients that time, but because there was a big talk about all these COVID spread and how different countries were struggling. So we got a lot of information when the patients were not with us. So you can see we are actually peaking, probably we have not peaked yet. We are still peaking, but we got a good time for us to prepare for our country. And our challenges are same as we don't have a very good health, facilities and backup plan. So I think the best thing which happened to us is the slow peak and early lockdown. Next slide, next one, please. Next. So you can see that, we are dark blue. This is WHO dashboard, and you can see we are second in the lineup. After US, we are there with the highest number of cases, and for very, obvious reasons. Next slide. Next slide. These are our numbers. Okay, so I think it's very important to understand our country's approach first, and then I will talk about the, medical facilities and, hospitals' attitude towards the disease. When I talk about hospital, my first-hand information is from my own institution, but I did have discussions with a couple of my friends, both from government setup and private setup. So I think very early, our Prime Minister has put up this early lockdown, which was in late part of March when we were not really seeing patients. And we had these 3 consecutive lockdowns, which actually gave us time to prepare our health facilities, makeshift hospitals, ICUs, and many super specialized hospitals were converted to COVID hospitals. And now we are in a slow phase of unlocking, and we're still not back to normal. A lot of facilities are still not on for people, but as people are definitely getting a lax about the disease, though the fact is we have still not reached the peak. Now, coming to hospitals' attitude, I will talk more about my institution. So because of this early lockdown, we got a lot of time to train our own staff, to prepare them mentally, to build up protocols, to go through the literature available or provided by other countries, like a lot of literature by Wuhan, Italy, and we build up our very strong protocols and put it on our, this is an intranet page of my institution, and you can see there are a lot of COVID related information, and this orange and yellow is to say that it's every day getting updated. Next slide, please. This is what happened in our department, anesthesia. We sat down a couple of core team and we made our own SOPs, and we are updating it every day. And we went through this SOP, the whole of our senior staff went through the SOP, and then after all that approval, we actually started implementing our procedural manual in our day-to-day practice. Next slide, please. So this is just just to say that this is how our SOPs are. Next slide. So this is just for an example. I've put a flow chart. Like if in previous slide, if you click on one of those pink lines, you'll get a flow chart like this. And this is a flow chart to say, let's say you have a surgical emergency in a patient who doesn't have ILI kind of symptoms, but it comes from high epi area, how to deal with these kind of patients. Do you do testing? Do you not do testing? It's an emergency. Where do you keep these patients? Where do they go post-op? So this kind of full flow chart has been developed for almost all the things which you have seen in previous slide. Next slide. So I think when we started, the first and foremost problem with the country and our hospital or many other hospital was to separate COVID patients from a healthy patient. So that was our first job, what was done in country. So country was divided into zones, orange zone, green zones, and red zone. Similarly, what we did in our hospital, we started off dividing our theaters into green zone theaters, which was our main OR, where 35 theaters are there. And then we divided, we dedicated one area with 7 operating theaters as our orange zone, where you can see, if you see, there is a duct there going on the roof of the operation theater, and that is all done by our own engineers in our hospital. So it's all local made, nothing in a cheap way we could do, convert our positive pressure theaters into negative pressure theater. And we had 2 dedicated red zone theaters, which were for COVID positive patients. Next slide. So when, so there are many things which anesthetist was challenged during this time, because we are the frontiers, and this disease spreads by aerosol generation. So for us at every level, there was a challenge. When you see these patients in pre-anesthesia checkup, there was challenge. When you deal with them perioperatively, there's the challenge. And the biggest challenge was the psychological support which the patient required and the healthcare worker required. That was a challenge. And then in our hospital, or in many hospitals, we have specialty based intensive cares. And when we came to this condition, we could not afford to have those specialties based ICUs. What we did was we just divided them into COVID ICUs and non-COVID ICUs. So there was no, so people actually divided themselves into working in a COVID area, not working in a COVID area. So though I do a lot of pediatrics, but I ended up doing a lot of adults during this time. Now, because we had early lockdown and we had patients trickling in later, we got a long time for us to practice what we wanted. So we got a lot of hands-on practice where we learned how to don, how to doff, how to do it properly. We started doing a lot of audits, how many people are actually sticking by the PP, the protocols. We started doing regular audits about the work and about the M&Ms. So what we realized actually in our setup that there was a rise in morbidity when we first started working, in this era or in this pandemic. And I think a lot was to do with getting used to this overalls, coveralls, dresses, and with the bad communication between two people, not able to identify each other, and we kind of sorted out each thing at every step. We did do a lot of researches based on the psychological impact on healthcare workers, and there was significant rise in stress, anxiety, and depression among
Did we lose her? We'll give it a few seconds, but I think we lost her. We may have to move to the next panelist as we wait for Dr. Rai to come back on. If we could just move to the next speaker. Julia. Thank you. So our next panelist is Dr. Adamson Phiri. Dr. Adamson Phiri, who's an anesthesiologist and CLEFT program coordinator and medical director at MIS Barthimée Hospital in Senegal. Dr. Phiri, you're welcome.
Thank you, Mary, and welcome for those of us who are participating in this webinar. It's a great opportunity to be here. I am going to share about the experience of my hospital. So welcome to Senegal. Senegal is in West Africa. It's the westernmost part of the continent with Dakar as its capital. But I am sharing experience from a town 72 kilometers away from Dakar called Chess. It's the third largest city. The hospital is a faith-based hospital. It's a 107 capacity bed hospital with almost every department, medical surgical department, except psychiatry and neurosurgery and cardiothoracic surgery, which we don't practice. I must say from the start that our hospital was not a designated treatment center for COVID-19. But an interesting thing is that the hospital was the first one to report personnel that were infected by COVID-19 in the country, and that was the beginning, actually, of community transmission in the country. So we had about 3 nurses and 2 support staff that were affected. And so because of that, the hospital kind of shut down in most of its activities. So we had a partial hospital lockdown. And the only thing that we kept running was inpatient care. And so our challenges there started flowing, including financial challenges, because we are a faith-based hospital. So we work on cost sharing for running costs. So that did a lot of a number on the financial issues of the hospital. The revenue went down. Our challenges in human resources, we realized that we were really not prepared at all to respond to a pandemic in any way, numbers, training, but most of all because we had personnel that were involved from the very beginning. We had to deal with psychological care of some of our members of staff, and that was quite a big challenge. We realized that our infrastructure and our equipment were not adapted to any of these this type of scenario. So our gap, the lack in our equipment and infrastructure was really magnified. It was really a very, very wake-up call, if you want to call it that way. Let's go on to the next slide. One of other area of challenges which I separate here is in terms of policies and systems. And here I think about administrative, political, and logistical support. We do have policies in place. We do have a system that functions, but all of these proved to be very inadequate with the pandemic. So we had to review, change, adapt, and this has been shared already by some of my friends on the panel. As the case definition evolved, you had to change a policy, you had to change a system because the case definitions kept changing rapidly. So patient care was based on the non-science at the time, and so policies and systems really were inadequate to handle the emergency for us. Like deciding, which case do you take, which person do you not take, which emergency do you take, which emergency do you not take, if it's positive, if it's negative, what you do. We had to look through our other areas like sterilization. The logistics really was a challenge for us as we navigated our way through this pandemic. So it really was a wake-up call for us. I mean, I've never intubated so many people out of my comfort zones. My comfort zones are the OR, the ICU, and the emergency room. But then you find that you have to, have advanced airway care in a ward or in an area that's not a comfort zone for you. So that was a challenge. It was a big challenge. As you can see, the solutions therefore were, redoing things. We had to rewrite budgets. The budget that we started with in the beginning of the year was apparently not going to save us at all. So we had to rewrite a whole budget, which came out 5 times, even much bigger than the original budget. We had to reconnect with donors and governments, restart our communications, and reevaluate our protocols and agreements with different partners. And training was a big issue. We had to, in a hurry, retrain and train people, reallocate resources, and realign our priorities. Like someone said on this panel, security of our personnel was our highest priority. And I think in anesthesia, that was more so very, very highlighted. We had to cancel leave for people. We had to buy new equipment. We had to train people in their use, in using new material, which we're not using. Even the using of virtual meetings, for example, was the things that we had to learn quickly and on the job. So, like someone said, flexibility was really the key. And I think this is one of the things that should go with us as we look to the future. Next slide. So moving on, I would like to propose a few, some of the things that we have laid down as resolutions for us to move on. Most of the things have been highlighted already by the other people on the panel, but safety should never be compromised. It should be budgeted for. It's a serious thing for anesthesia because of the exposure, especially for this novel virus, which is droplet and airborne transmitted. And anesthesiologists, dentists were particularly really at risk. So safety should really be budgeted for in all its forms, whether it's equipment, whether it's programs, training, whatever it is that assumes safety, it should be budgeted for. And then training should be taken into account. For those of us who are in the training, who are involved in training, I think we need to include training modules that target similar scenarios. We need to look at our curriculums and slot in our regular training curriculums responses to scenarios like this, and standardized training and care. I would like to say that some of the habits that we have learned during this time should remain. You know, like my hospital has really changed in terms of social distancing, and the furniture has all been moved around and changed. Patient flow has changed. Washing of hands has amazingly improved. And these habits, I think, should go beyond this crisis. And in my hospital, that's what we are trying to work at. So partnership across disciplines should be cultivated, because we realized that for us to make it through, we needed other disciplines like statisticians, like IT workers, to be able to handle virtual meetings, for example, and to be able to understand some of these platforms. It was amazing how much we realized that we needed IT personnel. We never thought we would ever need them that much that way. So the next slide. I would like to say something about government involvement, because I think our authorities were exceptional here in Senegal. And I don't know how many of you have seen the article on the USA Today that puts Senegal on second level in the way that they have dealt with this pandemic. But they analyzed and interpreted world events correctly from a distance, and they applied necessary measures in time. But they did come to the help of hospitals. We are a private, non-profit making hospital, but the government is not indebted to finances, but they did come up and give us a lot of finances and a lot of equipment, and exposed us to a lot of training materials and budgets. So I think that's a wonderful thing to highlight, that the political will is an important factor to engage in this fight. And they did encourage ingenuity. Local ventilators were created, hands-free washing equipment, which I think these things should be encouraged, and that should go on. So I think that's what we have learned in our experience here. I think this just summarizes what everyone else has said. And then the next slide, please. I would like to say that healthcare systems, we've learned now that we are frontliners. but I would like to say that we are also the last line of defense in many cases and in many ways. So that was our experience in a nutshell for our faith-based hospital. Thank you.
Thank you very much, Dr. Phiri, for sharing your experience. Sounds like Senegal is very exemplary and we should take a few lessons from it. All right, so we have Dr. Ekta has joined us again, and we will start off from where she left off. We'll be sharing her slides shortly. Okay.
Extremely sorry for this problem. I think one of the low middle income problem we had. There was a connectivity issue.
Yeah, sounds very familiar.
Yeah. So okay. So I think I did discuss all this. So at our department, at our level, what we did when we started hearing about COVID was first thing is we made a core committee and we went through all the articles which came out either online or whatever information came up, which was shared by China or Italy or different other European countries. We went through that, made a kind of SOP, and started working on that. I will discuss more in detail. Next slide, please. So I think the first challenge we had is how to deal with the pre-anesthetic checkup. In our OPDs, we do see around 10,000 patients per day. And to maintain social distancing with this number is just not possible. Actually, if you go to our OPDs, people touch each other. That's how it works. It's so crowded all the time. But luckily, because this, the numbers drop, the lockdown happened, and we reduced kind of our numbers by 30% to 30%, which means if we used to do 100 cases, we ended up doing only 30 cases because of lockdown, which was really a boon for our hospital specifically, because that could save us from crowding issue. And our main challenges in anesthesia clinic was how to decrease exposure of patient to patient, the disease, patient to healthcare workers, and at what level we decide which kind of cases we have to do. So initially when we started off, we really stopped completely the elective surgeries. We ended up doing only emergencies and essentials. Having said that, with emergencies and essentials also, we were running around every day 60 to 70 operations. It was only 30% of work. So basically what I'm trying to highlight here is the small problems were actually a big problem for our country, like how to maintain social distancing, how to keep hygiene, spot on. These were the major problems. And then what about the patients who have to undergo surgery? So we started kind of having telemedicine, started using telemedicine. The first doctor discussion used to happen face to face, but follow-up can happen with telemedicine. That's what we came up. And as far as our elective or essential surgeries go, we, after around 1.5 months of COVID into system, we made RT-PCR mandatory for all our patients. So it's only emergencies where they will do RT-PCR, but based on what kind of surgery is that, they will wait or they will not wait. But general attitude was to have this test done and take it to green zone theater, so that you don't have to, wear full coverall and find yourself in a difficult situation. Next slide. Now, I think acquiring safety gear was not a big issue for us, because initially we struggled, and then our country started to make it on its own. So we got our own country-made PPE, which made our life very easy, because the absence of adequate PPE was the biggest reason why people felt they were depressed or stressed out. So I think within a month we could sort out this problem. The initial 1 month was difficult, but after that we were okay. Now regarding N95 mask use, we reuse these masks, and different hospitals have different policies. Our hospital, we do H2O2 sterilization and use them, but we do understand the fitting sometimes really go bad, and then we have to, not use this mask. There's a little bit of flexibility, like a lot of us, what we do is we give rest of 72 hours to our mask and reuse that mask. And we are allowed to, use it 2 to 3 times, the same N95 mask. In our country, regional anesthesia is always preferred to general anesthesia. So this change was not a big change for our country. We always prefer regional over general, which continued in COVID time also. There was a hitch in using LMAs in the beginning, but now we started using our second generation LMAs, provided you have a good ETCO2 tracing and provided the fitting is all right. All are the modified approach to our intubation techniques. I think everybody follows the same, like RSIs. We did start using aerosol boxes, but then we realized it was quite cumbersome, and then a couple of studies came up and they said, it's harmful than beneficial. So we stopped that. So we grew every time, you have to keep yourself updated, and the mistakes maybe which were happening, we corrected. We definitely started using video laryngoscopes, and the CPR managements were modified. Patients were recovered in the theaters, the positive patients were recovered in the theaters. And the foremost important thing is to look after your own people. So all the anesthetists or all healthcare workers who were high risk for COVID, they were posted only in the green zone. Next slide, please. Now, ICUs were a big issue because, we have specialty-based ICUs, and during this time, you cannot afford to run specialty-based ICU because one, the number of cases reduced, the other, you're basically thinking about COVID and non-COVID scenarios. So we divided our ICUs into COVID and non-COVID, and people started getting rotated there. In other hospitals, what I heard is people are using recovery rooms as the PACU room as ICUs, but there are different challenges. And they initially, in the first 2 months, we did struggle with ventilators. And then, the PM supply came and we got these simple ventilators. There was an issue of initially doing a lot of invasive ventilation for all these COVID positive patients. But then over time, we have realized that non-invasive ventilation is the outcome of a invasively treated patient is much better than invasive, ventilation. So we moved from our policy of intubating everybody and treating to non-intubated patients. Next slide, please. Now, I think the biggest challenge of this COVID was how to handle the training for a postgraduate. When the caseloads have really come down to 30% of what you normally do. So I think compensation was done with online classes, with webinars, but I think they have to catch up a lot in their second years and the next years. Next slide. Now, I think this is the essence of the whole story. You need to give psychological support to your patients, to your healthcare workers, to your colleagues. So we do have a lot of, religious support, and a lot of talk by psychiatrists in our hospital, and it's not there everywhere in India, but what I know is there are many religious talks and meditation centers which came out online, and they conducted a couple of courses. So that's how support was given. Next slide. I think the best thing I felt during this COVID was there was never a lack of information. I think all the time we had lots of guidelines, lots of protocols, and we had a lot of our local country protocols also, which we could just copy and follow with some changes, obviously. Next slide. Now it's time, though we have not peaked yet, we have to peak still, but there's obviously this talk about resumption of elective surgeries have started. but it's going to be a little tricky. You need to make sure that you have proper supplies of your equipments, your personnels, you know, the PPEs, all that. And based on that, you have to open up your elective surgeries. We are not open yet, but I know a lot of hospitals have started working. And this is something, it's going to be another big challenge for all of us. Next slide. If I have to say lesson learned during this COVID, I think organized approach. I think we benefited with the early lockdown, which flattened our curve or graph. Use of digital media for sharing knowledge and facing the situation logically. You know, application of guidelines logically to your setup. I think this is what we learned from this COVID, though we have a long way to go yet. Thank you. So this is a small, gallery to show how we are running our theaters, our ICUs. This is just last week I took, and there are two sim-mans you can see. This is in the beginning of COVID time when we were running simulations and trying to train our people, and changes like adding filters to your expiratory limb before, sampling line, all those changes were done. And with this, I end. Thank you.
Thank you very much. I'm glad we got you back just in time. So at this point in time, I noticed Dr. Fauzia was responding to the questions as they came in, which is great. I would like to just go on and ask the panelists. I'm opening it up to everyone, and I'd like to encourage the audience and the participants to just keep their questions coming. So I'm just wondering about the testing for the pre-op patients. How are you going about the testing? Are you testing all the patients as a baseline? Is everyone that comes into the hospital that needs surgery, are they all getting tested? What kind of testing are you doing? And what are you using the test for? And also, for those who deal with pediatrics, you testing the guardian or the parent as well? Thank you. We'll just speak up and yeah, any of the panelists.
Yes, Mary, yes, we're just testing all our surgical patients. Initially, we were asking for the test to be done within 48 hours before they presented for surgery. But now we've extended it to 72 hours. This includes pediatric patients as well, but we are not testing their parents. It's just the patient that we're testing because the test costs money. And, there's an issue of additional cost to the patient coming to the hospital.
So can I add on here, Dr. Mary?
Yes, please.
So as Dr. Fauzia said, the testing costs around $50 for us if I have to convert our 4,000 rupees. So money is an issue and it's paid by patients. We are testing all our elective patients. We are doing RT-PCR and it takes around 12 hours for us to get the result. We run 3 tests in a day to kind of cover all our patients. The test we consider validity of test for 5 days, and we accept 5 days.
Okay, Dr. Phiri or Rebecca?
I'll come in with the South African experience, with our Cape Town experience. So we, when we started testing all our patients, it was a few months ago, and we were waiting up to 72 hours for the test results to come out. And that was difficult because at that stage we were only doing emergency surgery. It's improved now. We have got more testing available, and also our overall case numbers are decreasing, so that also makes it easier. But we're still testing all patients, all elective patients and all emergency patients. and they usually come in the day before for the test. It's, you know, the validity of the test, it's very tricky to say, because really it's only testing them up until that point, and if they go back home, they're still, you know, going back into their house and back into their community. It's very difficult for people to isolate completely. If we can't wait for a test result, and this certainly was more of a factor early on when we were waiting 72 hours. So if we've got a patient for an emergency and we couldn't wait for the result, we would screen them, and we always screen them and their parent with a set of screening questions. And if we felt that on screening they or their parent were likely to you know, if they screened positive for COVID symptoms, then they would be treated as COVID positive. If they screened negative for symptoms and we hadn't got the test result back, we made the decision not to do them in the COVID theatre, because operating in the COVID theatre was A, use the resources, but B, it makes your operating more challenging, and it does increase your risk as well. So we find the communication difficult through all the PPE. We find surgeons, everyone gets quite uncomfortable. And that, you know, does compromise some patient safety as well. So it wasn't a simple matter of, well, if we can't get the result, we'll just treat everyone as though they're positive, which is what we used to do, you know, in the HIV era. We just had that blanket rule that you know, just assume everyone's positive. So we didn't take that approach. We just took we called it the new normal, which was we were cautious with every airway handling, with any aerosol generating procedures, and we would try and minimize people in theatre for intubations and extubations, but then the people doing the intubations and extubations would be wearing a plastic apron, an N95, and eye protection. That's our sort of new normal now for everyone. The other thing is that the tests, the PCR tests, are, you know, they've still got quite a high false negative rate. So when you do get a negative in an asymptomatic patient, yeah, it's you know, you still have a possibility of having it positive. So that gives you that the need to be cautious with every intubation. And we've been caught with our pants down once or twice, where we've had patients who've screened negative, and we've had to push ahead with surgery before we've got their results. And because they've screened negative, we've put them in, not done them with full PPE, and not done them in the COVID theatre, and they've come back as positive subsequently. And then those, you know, we deal with based on what their symptomatology was like. I was involved with such a case recently when we interrogated what the chance of exposure to the anaesthetist was, and we discussed the symptomatology of the patient. The patient was completely asymptomatic from a COVID perspective, and in discussion with our infectious diseases doctors at the hospital and the people who've been developing the protocols as we go along, and based on our current understanding of the disease and the way it manifests, the decision was made that that child was, even though the result had come back positive at that stage, was very unlikely to be infectious. And given the fact that the registrar or the resident in question had used our new normal precautions, which was wearing an N95, wearing eye protection, having a plastic apron and gloves on, although that's not full PPE with a, you know, the surgical gown and so on, the decision was made that he would then self-monitor. And he didn't isolate, and then he tested at 5 days, which is our protocol for healthcare workers, and tested negative. So yeah, I mean, the lesson for me there was that we just, you know, it's constant vigilance. So that patient was unexpectedly positive. It's still going to happen.
Thank you very much. You sort of answered quite a bit of forthcoming questions that I was going to ask. And I see a really good build-up from that Q&A from Esther Njoroge. And she says, excellent presentation. Thank you all panelists. In many African countries, testing is limited and mostly quite costly. What's your blanket advice as more countries reopen? Rebecca, would you like to go first?
Yeah. And anyway, testing isn't, you know, it's only 70%, you're going to pick up 70%. So I think screening is still very important. And when patients are symptomatic, our current understanding is that those are the patients that are more likely to have high viral loads and transmit. I must stress that it's just such a constantly evolving situation. I'm not used to working with so little actual known facts, and a lot of our decisions are based on speculation. And you know, all of these sort of absolutes that we're so used to working with in medicine is just not there anymore. So my thoughts on that would be to screen patients, and if there's any screening that's positive, then you know, treat them as positive, and adopt the new normal approach where you are really fastidious with your own personal cleaning of yourself and protection of yourself. We had an interesting study that just came out in South Africa, which in Cape Town particularly, which looked at antibodies, and it showed that about 40% of people who are accessing public health have actually got antibodies. So we're looking at about 40% of the population have probably already had COVID, which is obviously much higher than what the testing is showing, and that's because our testing was so restrictive. You know, during our peak, we had to limit the number of tests we could do. We didn't have a lot of testing available, so it was only limited to people who were over 55 and were symptomatic enough to need hospitalization, or healthcare workers. So we, you know, massively under-detected, which we knew we were doing anyway, the number of cases. So about 40% of our population who access public health in the Western Cape have probably already had coronavirus. So there's an element of herd immunity there. So yeah, I mean, I'm putting that back into the mix as well. The chances of us having big spikes, peaks of infection and spikes is going to be less. So it's vigilance, but hopefully we're not going to get back towards the real high points that we had previously. Too sure that kind of helps answer it. It's just, you know, maybe just a little bit more.
I hope, yeah. Thank you very much, Rebecca. I hope Dr. Njoroge got a good response to her question. So the other question I would like to ask, forwarding from the chat room, I see someone asked, did you have a machine that was contaminated? And if yes, have you had a machine, to all the panelists? Have you had a machine contaminated? And if yes, how did you clean it? Ekta responded to one of the responses, and he said he always used to filter.
So I mean, I think if we are thinking about contamination of the circuit, it's to throw the circuit. Soda lime can be exchanged. Generally, we use filters on our expiratory limb and, you know, at the patient end. So I'm assuming that your machine parts are not contaminated, because if they are contaminated, I think it's a big issue. So I'm not sure what to do if the machine internal parts get contaminated. If
anyone else can say something about this? Any of the other panelists?
I actually just wanted to say something about something earlier on about blanket advice.
Yes.
Yeah, in my region here, the tests are very expensive, actually much more expensive than Dr. Rai's. We are at $100 a test. So it's not practical for us to test. So we are not testing our patients, but we have progressed carefully in screening. So we won't take at-risk patients a certain age. And if they have comorbidities, for example, we would want to make sure that they don't fit the case definition. So we are approaching it that way, and then using a lot of anesthesia that avoids the airway, like local regional anesthesia, and selecting cases. So some of our patients actually go to the OR with a mask on, and they have a mask on through the whole surgical time. So that's how we have kind of picked it up. There is testing available, but it's very expensive, and it's not very useful for us to do that. And then we do quite a very strict screening using the inexpensive material that we have. Chest X-rays tell us a lot, especially in at-risk patients. So it depends the resources where you are, but where we are, testing everyone would mean another sort of lockdown, because that's really probably not very practical right now. So we don't test, we screen, and we operate carefully.
Thank you very much for that. So I just want to go back to the question of contamination, and just want to say that in low resource settings, in limited resource settings, sometimes there's equipment that you have to reuse just because you can't discard it between patients. You can't change it for every patient. It's not recommended to reuse these things, but if you must reuse them, you have to be sure that the decontamination is high grade. And so there's a lot of resources out there. Lifebox has some resources, WFSA has some resources giving guidance on how the decontamination of equipment can be done. And those are some very good places to go and see how this can be done safely. But indeed, using the 2 filters for the machine is one way to protect the equipment and then every patient, and then just cleaning the surfaces with 70% alcohol or 0.5% chloride solution. I just noticed the poll that was shared that almost 100% of the people in this discussion have resumed elective surgery, which is quite interesting. And then there was a question on whether we're using the COVID-19 surgical patient checklist, and 55% are using this checklist. And well, I wonder why 55% are not, 75 or 80% using the checklist. Is it that it's a bit confusing to use it alongside the surgical safety checklist? Or is it that we have our own guidelines and checklists to follow in our facilities? Any of the panelists could help answer this question.
I think, like in my country, there are no national guidelines on this, and each institution have their own guidelines. I think that's probably the reason. So this may be happening in other places as well.
And I guess it shouldn't be too surprising, because up to today, the WHO surgical safety checklist is not used 100%. So maybe it will take some time to catch on. All right, just a quick look through the Q&A. Dr. Elizabeth Igaga is asking, how do you handle patients who test positive immediately post-operatively and were negative preoperatively? Asking about both the patient and human resource in contact. Anyone in the panel could answer this.
Yeah, we had a situation like that with one of our orthopedic patients. They showed symptoms fitting a case definition in the post-op period, which made them qualify for a free test. So we did the test, and then it was positive. So we just followed protocol. The patient was isolated and put on recommended treatment besides the treatment that they came back with. But then the personnel that was on duty that day was quarantined for the recommended period of time, and then tested, and they did come out negative, all of them, and the particular OR was closed down for that period of time, and disinfected, and following the procedure and the guidelines that we are using right now. So that was one experience that we had with the patient in the post-op period, and it ended well. The patient recovered, didn't develop any more problems. The personnel have since started, and the OR is up and running again.
Thank you very much for that. Any other responses? Does anyone handle their cases differently?
We did have a couple of experiences like this where a pre-op patient was negative and post-operatively turned out to be positive. So there were many issues into this. One is the safety of healthcare workers. So I think as an institution, we follow a policy saying that if you have exposure with a positive patient for 30 minutes without mask, you will be quarantined. And if it's less than this time interval, or you were wearing your N95 mask, then you are quarantined only for 3 days to see if the symptoms appear. If you had no mask, then you're quarantined for 7 days to see if symptoms appear. So that's regarding the healthcare worker. Now coming to patient, obviously gets isolated because now is a positive patient, has to move to other block altogether because you have a separate area for COVID positive patient. But it doesn't end here, because in India, I'm sure, as I heard Dr. Fauzia in Pakistan, there's a lot of repercussion, patients asking a lot of questions. How did he get infection? So you know, it's a little more complicated than it sounds. Then you have to convince, you know, the test is not always 100% positive, you know, 100% tells you the result. So a lot of convincing goes into this aspect, and you never know whether patient actually got infected while getting treatment, or, you know, you don't know how it happened. So there are many aspects to it, but I think that's how we deal with it. I don't see solid evidence to say this, but that's how our institution follows, and that's what we follow. We don't test any of our healthcare workers. If they don't develop symptoms in next 7 days, they're back to work.
Okay. Reasonable. All right, thank you very much, everyone. I think we've had some good questions and comments. I'd just like to read from someone in Switzerland, and she said they do not test systematically in Switzerland, as they have noticed that in asymptomatic patients, less than 1% were positive. And so they screen, and symptomatic patients are postponed. You know, it just sort of begs the question, why do we have to test anyway? Thanks everyone for attending this town hall discussion. I'd like to hand over to Dr. Joe for some concluding remarks. Thank you.
Well, thank you, everyone. This has been a fascinating discussion. I just want to touch on the fact that as far as like myself as a surgeon, like Megan, the anesthesiologists are really the front line. You guys are up by the airway, and this pandemic is an airway issue, really. It's not in the abdomen where I work. And so we really appreciate this insight from all of you in this whole area. And one of the things that I'm interested in, and just not to take on the discussion much further, but there is some early data coming out saying that an asymptomatic patient undergoing elective surgery had a much higher mortality rate. And so this becomes a huge issue for all of us as a surgical team together to sort out the best way forward. And we've heard very different approaches, from Dr. Phiri's approach at his hospital to Dr. Rai's approach. I mean, to see the differences in the tertiary care centers to the district level hospitals, we know there's a wide variety of PPEs available for staff, keeping our staff safe, but also being able to test. I'm really surprised that a test costs $300. For me, that's shocking that us as a global health community can put up with that. But I'm really appreciative of all the speakers. Thank you so much for your participation. And I just want to take a few moments to open the floor to Aaron Stieber and to Faye Evans for our co-sponsors. So Aaron, maybe if you could just say a word of encouragement to all the team members from Smile Train out there, please go ahead. And then Faye, if you want to say a few words as well.
Yeah, thank you so much, Jeff. This was a fantastic panel. I think, Dr. Phiri, your point that in this pandemic, our anesthesia providers are on the front lines and also the last line of defense really resonated with me. And that's absolutely true in surgical safety and quality too. So it was really wonderful to hear everything that all of you are doing, all of the strides that are being made that we can maintain when this pandemic ends, to continue safety and quality in all of the procedures. And we had a number of Smile Train partners and providers on the webinar. So we were just thrilled to have you participate in our programs on an ongoing basis, and then to hear more from you and your expertise today. And we were also really thrilled to help convene this discussion with UNITAR, GSF, WFSA, Baylor College of Medicine, LifeBox, and GICS. It's such an important topic. And I think this was a really great way to cover the needs and the strengths of our anesthesia providers during the pandemic to ensure safe surgery. So thank you, everyone. And Faye, I'd love to pass it over to you.
I'd like to say, really on behalf of the whole anesthesia community, thank you to all of our panelists for sharing your experiences. I think what was really interesting is to see the common themes on how the anesthesia community really has come together, and how we communicate so well these days with WhatsApp, and how quickly information gets out to one another, regardless of whether you're in India, the US, in Uganda. Information really does spread rapidly. Sometimes good information, sometimes bad information, but I think the community is working together to try to deal with this situation. I also thought it was really interesting that all of your talks touched on innovation to maintain safety, not just for our patients, but also the healthcare workers and our colleagues. So that was really a priority. I think our ability to be flexible in these situations has been incredible. I think a reminder of the need for psychological support. I think it's all too often that we all work way too hard and we're not looking out for the well-being of each other. And then finally, I think just to emphasize the need for partnerships, not just with our healthcare workers, but also with the IT specialists, as we've come to really rely on technology to communicate. Everybody is just super important. So just thank you very much. Jeff, back to you.
Well, thanks, Faye and Aaron, for those words. And once again, just thank you to all the panelists and to the attendees, and for the questions that came in. Very stimulating, and I think that the discussion will have long-reaching effects. It will be made available in video format on the UNITAR and GSF websites. It'll be a few days until we can get it up there, but please feel free to share that with your colleagues. And there are other previous webinars on the GSF website as well in the same topics. So once again, thank you very much. A big thank you from UNITAR and the Global Surgery Foundation and to all of our partners. So have a great day and keep safe. Thank you.
Thank you. Bye, everyone.
Thank you.
Thanks,
everyone.
Thank you, everyone.
Thanks.